Our first presenter is Dr. Michael Kramer. He's an associate professor and director of the Emory Maternal and Child Health Center of Excellence. Sounds like a great thing, Michael. His teaching and research focus on the intersection of policy, social, and contextual environments and maternal and infant health outcomes, particularly for us in the Southeast. His work is supported by and in collaboration with the CDC, Georgia DPH, and HRSA MCH Bureau and foundations. Dr. Kramer's research includes social determinants of health, including the study of macrosocial determinants of population disparities in life course health outcomes, including pregnancy outcomes, childhood development, and adult chronic disease incidence and mortality. Such macrosocial determinants are observable at different scales, and thus his work is focused on both neighborhood effects as well as broader regional and subnational processes, including racial and economic residential segregation. This line of research includes both ideologic mechanistic analyses as well as evaluations of social policies as determinants of health, including shifting public housing policy in Atlanta. In a life course perspective, reproduction and early childhood are particularly critical windows during which social and environmental exposures may have an outsized role in patterning health trajectories throughout the rest of life. Much of Dr. Kramer's research on maternal child health has focused on biosocial and macrosocial determinants of racial and economic disparities in preterm birth and in maternal health, morbidity, and mortality. This line of research also includes ongoing collaborations with the March of Dimes and CDC, developing data visualization tools to facilitate state and local surveillance and action to eliminate inequities in poor perinatal and maternal health outcomes. Dr. Kramer continues to research spatial patterns of population and population health, often reflect the geography of social processes. This line of work includes validating and implementing novel methods for measuring spatial segregation and community resources at varying spatial scales in an effort to more fully represent the ways in which people experience place. How do people experience place? Ongoing funded research in spatial analysis sounds really exciting to me. Focuses on the geography of opportunity for maternal and perinatal health outcomes. Please join me in welcoming Dr. Kramer, who's going to talk to us about changing the conversation, maternal, fetal, and health equity in Georgia. Dr. Kramer.
Great, thank you so much. Good morning, everyone. I hope you all are well. Let's see. What do I have? Okay, there's not a. Is that the green button? The big green button. Oh, that's easy, isn't it? Okay, perfect. Good morning again. My name is Michael Kramer, and thank you so much, Dr. Levine, for that kind and too long introduction, more than you wanted to know about me. It's an honor to be here with you all today. I've been sort of on the tangent, on the edges of different activities that GaPQC has been engaged in over the years. And it's really a joy to be with you and share a little bit today. I'm going to talk about health equity, and I recognize that I come to you with a talk about social determinants of health and health equity, even though you are a group who has been spending a lot of time thinking about these very issues. You're not new to these issues. So I'm going to cover some content that may be review or maybe familiar, but hopefully some new ideas as well, or at least some new hooks to hang ideas on as you're moving forward. So I have no disclosures or conflicts of interest, and these are my objectives, which will be achieved or not, regardless of whether I read them. So I'm going to go past that. Okay, so maternal and infant health in Georgia, where do we stand? You all may be familiar with the fact that Georgia is not doing so well ranked in the US at large with respect to maternal and infant health. So this report came out in 2018, I believe. The report came out in 2018, identifying Georgia's ranking with respect to maternal mortality near the worst in the country. Our 2022 March of Dimes report card also doesn't look so great. An F grade for our preterm birth and higher than average infant mortality rates. Now, when we think about equity, we can think about equity across many dimensions, and I'll talk about each of these dimensions through the course of today. One dimension is how we observe or see equity or inequity in outcomes across geographic units. So, for example, geographic variation in infant mortality or maternal mortality is one thing we see. We can see that across states, across counties, across neighborhoods, between rural and urban areas. There's also inequity along socioeconomic lines. So this idea of a very consistent and replicable gradient in the occurrence of a wide variety of perinatal outcomes, including infant mortality, which is shown here, where we see those with more resources and more affluence having lower risk of poor outcomes than those with fewer resources and less affluence. And of course, we see inequities across racial lines. So the racial disparities in a number of perinatal outcomes are what motivate a lot of the work that we're doing. Now, I'm going to spend more of my time and examples illustrating the racial disparities in perinatal outcomes because that's a particularly salient issue in Georgia. Geographic disparities are also really important. And I'm just going to start off by giving a snapshot of where we stand with respect to equity in Georgia. So if we think about preterm birth in 2021, each of these, I'm going to show us a series of these graphs, but each of them has the absolute rate of the outcome in that bar graph on the right. And so you can see that, for example, for non-Hispanic white women, preterm birth in 2021 was about 10%, it was about 15% for non-Hispanic Black women. So if we take a ratio of those two, that's the disparity measure we often describe, we would say that the Black-white racial disparity was 1.5, or there's a 50% excess risk of preterm birth in Black as compared to white women. If we look at low birth weight, that racial disparity is actually twofold. So this 2.0 means that there's twice the risk of low birth weight in Black as compared to white infants. Infant mortality is also about twofold in 2021. Maternal mortality, the Black-white racial disparity is about 2.1. I want to point out that nationally, the Black-white disparity is about threefold in maternal mortality. And that would make it seem like we're doing better in Georgia. But unfortunately, the reason our disparity is smaller is because white women are substantially higher risk in Georgia than they are in other parts of the country. So a disparity can get smaller, not just because one group gets better, but because another group gets worse. So we see a smaller gap in Georgia because white women are experiencing higher burden than white women in other parts of the country. Very low birth weight, a baby born less than 1,500 grams, 2.5-fold difference in 2021. All right, so that's just a high-level picture of where we stand, at least with that one dimension of equity. Clearly a lot of work to do. So let's think a little bit about what it means. So Dr. Levine mentioned this importance of a health equity lens in your mission. And again, I recognize that you all spent a lot of time thinking about this. So I'm going to talk about what I think about a health equity lens from a few different angles or points of view and how we can begin to approach what are the causes of inequities and what might be possible solutions. First of all, just acknowledging that this idea of equity as opposed to equality, equity has a particular definition. CDC defines it when equity has been achieved when everyone has the opportunity to be as healthy as possible. And the World Health Organization says it's the absence of avoidable or remediable differences among groups, whether those groups are defined socially, economically, demographically, or geographically. So it's often through some social or population demographic that we use contrast to understand inequity or equity. You may have seen these kinds of metaphors or images before. I'm just going to walk through this idea of distinguishing between equality and equity, because sometimes that can be confusing. So we can see this sort of cartoonish picture of these two children who want to get an apple. And there's an inequality because one of them has an apple and one of them doesn't have an apple. And so we could think of an intervention that would be equally implemented. So we could provide them both with a ladder. But an intervention that starts from the point of view of equality doesn't necessarily address the problem. You can see that giving each of the children a ladder provides access to the apple for one of them, but not for the other. So we might think of equity as the provision of the resources that are needed to achieve the best outcomes possible, using the CDC definition. So in other words, providing people with the resources they need and not just identical or equal resources. But you might notice that the reason we needed to do that was because there was this structural explanation for why one child had more access to the apple than the other. And that's that the playing field was uneven or the tree was bent. So we can think of justice, fairness, as efforts that seek to create a level playing field so that everyone is starting from the same point and has access to begin with. So that's kind of a cartoon version, but now I want to try and talk about what the implications are of missing this equality versus equity distinction when it comes to implementing public health interventions. I'm going to try and illustrate it by talking about the history of infant mortality in the 20th century, which may seem like a stretch. You'll decide whether it's a stretch when I'm done or not. So you've very likely seen graphs like this. This is a picture of our trends in infant mortality in the United States by race. The top line is labeled non-white. That's because on vital statistics in the early part of the century, that's how people were categorized, as white or non-white. For the most part, in the early part of the century, people who were categorized as non-white were Black or African American. So this is roughly a line of Black or African American on top and white on the bottom. So one of the things you notice is we've made an immense amount of progress with respect to infant mortality. Infant mortality has declined substantially, and that's a really important public health success. When people have investigated the explanations, like what was it that we did that made infant mortality go down so much, we see things like this. We've got things like the implementation of clean water and adequate nutrition, vaccines and infection control. So these are sort of public health primary prevention things. Access to safe labor and delivery, but also important innovations and technologies around advanced medical care. So medical technology and care that improve the survival of infants. So we see this incredible amount of progress, and we should feel proud that we, over a period of time, have made a real difference with respect to infant mortality. But if we take that previous graph and we create a black-white disparity measure, the rate ratio, this is what it looks like. This looks different. What this is saying on the y-axis is the rate ratio, the disparity, the relative gap, is that basically the black-white gap in infant mortality has been about twofold for 100 years. It is virtually unchanged. It goes up and down a little bit, but we have not made progress in eliminating this relative gap. Now, just a reminder, the way a relative gap is calculated is by dividing the rate in this case, infant mortality rate for Black infants divided by the infant mortality rate for white infants. So that means even as the rates are going down, we can always divide those numbers and say, is one group twice as high as the other? And the answer is that consistently, we have this twofold racial disparity. We were really interested in why this occurred. Just from a purely mathematical perspective, it seems hard to fathom that disparity would be so persistent for so many decades, given that the causes of death changed, so many things changed about our environments, but that pattern persisted for 100 years. And so we dug in a different way. We thought about some cause-specific explanations for infant mortality. Now, this is a little fraught. We're using a lot of historical vital records to try to identify cause of death, which was marked on death certificates. But to the extent that it's possible with the records available, we were able to identify a few patterns and a few causes. And so what I'm showing here is infant mortality that is related to gastrointestinal disease, often diarrheal diseases, particularly earlier in the century. So again, this is a plot where on the y-axis is the black-white racial disparity. So you can see that it's down at 1, that would be that there's no disparity at all. Where there's a 2, that would be a twofold disparity, 4 and 8. Now you notice that the black-white disparity started relatively small, say in 1920, maybe it's 1.5 or something like that. But around 1940, it began increasing so that there was actually a racial disparity in infant mortality caused by GI disease of around 6-fold in 1960 or 70, and then it goes down again. And that seems like a really strange pattern. This isn't about the absolute rates. This is about the disparity, the gap between Black and white. So what explains this? Well, there is another number of possibilities, but some really interesting historical work about changes in mortality patterns point to the fact that this early part of the century was the time when cities were systematically expanding their clean water, municipal water treatment, and we were getting indoor plumbing everywhere. We were essentially making this huge infrastructural public health intervention that took decades to accomplish, that really had an impact on people's access to clean and safe water. But it's probably not surprising that given that it took decades, we didn't randomly select which communities got clean water first. The communities that got clean water first were systematically communities that were wealthier and whiter. So one possible explanation is when we see that racial disparity going up, this doesn't necessarily mean that Black babies started having more GI disease. It's that white babies started having faster decline. They improved quicker because they had earlier access to this public health intervention. Now, of course, at this point, most people have access to clean water. There are some important exceptions. We can think of the Flint water crisis, for example. But most people have access to clean and safe water. So we can think of that intervention being equal now, but in terms of its implementation, it was inequitable. Okay, so let's think about another cause, prematurity. We know prematurity is a really important driver and cause of infant mortality. So here's the Black-white racial disparities in infant mortality with prematurity as an underlying cause. And the shape is similar, but it's shifted a little bit. You see, once again, in 1920, 1930, relatively small racial disparity. That doesn't mean it was an unimportant cause. It means the gap between Black and white was relatively small. But say in the 50s, 60s, 70s, we see that the disparity increased, excuse me, and then a slight decrease. So another interesting piece from our history is the introduction of NICUs. NICUs were an incredibly important, highly intensive medical technology that was introduced, and it substantially improved the survival of very small babies. So babies that were born preterm had higher survival if they had access to a NICU. Now, at this point in time, we know that NICUs are relatively ubiquitous and any preemie baby should have access to a NICU. But when they first began, access to the specialist services was not necessarily equally distributed, and it wasn't randomly distributed. Once again, access to NICU services was more likely to be available for whiter and wealthier communities and less likely to be available for Black and poor communities and for rural communities. So once again, we see the disparity increasing, not because Black infants were dying more from preterm birth during those particular decades, but because the improvement in survival among white infants was faster. And then there was this reversal. Now, the last example I'll just go through quickly. The pattern is not nearly so strong, but this is looking at SIDS or SUID deaths. Of course, we didn't have an ICD code for SIDS prior to 1980, so that's why the line begins there. But we do see a little bit of this kind of pattern of a disparity, a Black-white racial disparity in SIDS that increased. And some people have posited that when AAP's initial recommendations, when SIDS was identified and the beginnings of the Back to Sleep campaign began, that some of the methods of communication, the health education, was biased in the sense that it was more readily adopted by more educated people, by middle-class people, often by whiter and wealthier people, and that the communication was not as successful when it came to non-English speakers, when it came to low-income folks, et cetera. And so we may see in this case, the difference in the access to this new resource, education, was about the means of communication. Now, of course, there were a lot of efforts and have been a lot of efforts to improve how we message and communicate Back to Sleep now. So here's my take home from this little vignette, this story, and it has to do with this distinction between equity and equality. We make progress in public health through innovation. We had innovation by implementing clean water. We had innovation by improving medical care in NICUs. We had innovation by developing the right evidence and messaging around how to prevent SIDS. So innovation is important, but equity requires a special attention to how we implement innovation. If we just develop a new innovation and we let it go kind of through market forces, it almost surely will benefit people with more resources first and will benefit people with fewer resources later. In other words, it will systematically reproduce the disparities and inequities that we see. One of the reasons I believe we see this persistence in the twofold racial disparity and infant mortality is not because people don't eventually get the innovations. It's that at every step of the way, who gets them first, who are the early adopters, is structured by things like access to resources. Okay, so that's my sort of take on like, why is this equity thing important and why should we distinguish it from equality per se? That we really need to think about what is a level playing field and where are we starting from and how do we implement? So let's talk a little bit about what causes perinatal disparities. And I'm going to use an example in just a moment. Well, let me talk about these two maps first, just to give some grounding. I'm going to give one example from maternal health and one example from infant health. I said that I'm interested in equity and disparities across a number of dimensions, including economic, racial, geographic. This is severe maternal morbidity at the county level, so based on county of residence. And the map on the left on your screen, the map on the left is the prevalence or the rate of severe maternal morbidity at the county level for non-Hispanic Black women from 2016 to 2019 by county. The middle is the same rate for non-Hispanic white women. And so we can see a couple things here. We can see in each of these that there's geographic variation in where SMM is higher or lower. And if you compare back and forth, there are some places that are high for Black women, but not for white women, and vice versa. So in other words, the geographic patterns are not identical by race. Now, the map to the right is actually quantifying the racial disparity. So in that case, the beige, orange, red colors are higher disparities. Black women have higher SMM than white women. The green actually is the inverse. It's areas where there is statistically no disparity or maybe even an inversion. Again, the reason for this is not that those counties are having great success. It's that white women in those counties are having exceedingly high SMM. So what we're seeing here are racial differences in SMM, but also geographic differences. This is the same idea, but this is infant mortality, okay? Black infants on the left, white infants in blue in the middle, and then the racial disparities on the right. And again, patterns of geographic variation. So the rate of infant mortality is not the same everywhere in Georgia. And also racial differences. The patterns are different by race and the magnitude of the disparity is different by place. Okay, so I start with those to say, I'm interested now in talking about why disparities occur. And I think this approach to how we ask the question, why did this disparity occur, is really important. And I'm going to use as an example, thinking about understanding why babies are born low birth weight. So what I have here, this sort of purplish bell-shaped curve, is actually a distribution of all the babies born in 2017 in the US based on their birth weight. So birth weight is on the bottom on the x-axis. So you can see we've kind of cut off the tails, but we've got babies down to 1,000 grams, babies up to 5,000 grams, and most babies are, you know, kind of at 3,200 or something like that. In other words, we've got a nice normal distribution of birth weights. This is what we see in lots of populations. That red vertical line is 2,500 grams, so that's our conventional threshold for low birth weight. All right, so if we have something like this, and we want to know what's going on, what we often do is ask the question, why did this baby have low birth weight? In other words, we're asking, like, why is a baby on the left-hand side of that red line as compared to the right-hand side? And we might do studies where we get all the babies on the left-hand side, the low birth weight babies, and all the babies on the right-hand side, the normal birth weight babies, and we compare stuff about them, right? So that's basically a process of asking what differs between individuals or what's the cause of this case. Now, this is a really successful strategy. We've identified a ton of things like broadly, you know, infections are important, stress is important, smoking is important, genetics important. I've got race here with a question mark because for a long time, people identified race as an individual risk factor for low birth weight or for other perinatal outcomes. I'm going to return to that and explain that question mark in a moment. So this is a pretty conventional approach that's used in clinical medicine, that's used in public health. Okay, what if I took those exact same data? This is still the distribution of the birth weights for all the babies born in the US, but now I'm stratifying it. I have one curve, one distribution for babies born to white moms and one for babies born to Black moms. Okay, so a couple things stand out to me about these curves. One is that the shape of the curves is nearly identical. Like what that means is there are big babies and there are little babies, and most babies are average. Right? In other words, individual babies are different, and there's lots of reasons why individuals are different from one another. So in both cases, in Black and white infants, individuals are different from one another. But the second thing that stands out is the entire curve for Black babies is shifted to the left. So it's not just that we shifted some from the middle out to the low birth weight. The entire curve is shifted to the left, which I think is interesting. And one consequence of that is a lot more Black babies are pushed across that red line. So we have this higher prevalence of low birth weight. All right, now when I see a plot like that, it makes me ask a different question. Instead of asking, why did this baby have low birth weight? What's different between this one baby and this other baby? It makes me ask, what is the different experience of Black moms and Black infants as compared to white moms and white infants? What is a shared group experience that's shifting the entire distribution? What differs between populations, or what is the cause of incidence instead of the causes of cases? And when we ask the question in a different way, if we just shift our frame a little bit, maybe instead of asking about individual race as a risk factor, we say, maybe there's an experience of racism that's causing a difference in the whole distribution of birth weight. Maybe there's differences in experiences of stigma and discrimination, segregation, opportunity structures, healthcare access. Okay, so this is one idea that I think can sometimes help us as we're approaching problems, is separating when we're asking a question about what makes individuals different from one another, and when we're asking questions about what makes disparities occur, what makes differences between groups. Because there could be true answers that are different from one another to each of those questions. We could know the truth about what makes individuals different without understanding the truth of what makes groups different. We have to ask the question. Okay, so now let's think a little bit about how does that happen? What does it mean that some of those things somehow shaped a group level experience, shifted that curve? So this is a framework that we developed originally for helping maternal mortality review committees, but it could be applied broadly to lots of perinatal examination. So in this framework, I'm going to highlight just a couple things. This is centered, obviously, around this mother-infant dyad, right? We've got this pregnant mom in the center here, and we're understanding kind of causes of her wellness. And at this level that's at the bottom, and I would call it under the skin, the things that are inside of us, this is underlying health and physiology, right? This is the stuff that clinical care is well designed to examine, to interrogate, to address, to treat. So thinking about cardiometabolic health, neuroendocrine health, immunoinflammatory health. Now I've got this horizontal axis, which is the life course, and that's just the reminder that all the determinants of perinatal outcomes probably are not mapped from the moment of conception to the moment of delivery, right? Probably mom's health before she got pregnant is important. Things like family planning, things like access to primary health care and control of hypertension or diabetes, things like life course stressors, early childhood experiences, etc. So the life course is important. Now, what is on the top of the screen, these are things I would say are above the skin. And so one way to think of this is each pregnant person, each of us in this room navigates the world and makes decisions as a hopefully rational actor. And we make our decisions and choices around our health and our behaviors in a particular context. It's as if we have a menu. We don't have an infinite menu. None of us has an infinite menu. We make our decisions in the context of constraints and opportunities. So let's think about what are the regulators of our constraints and opportunities as we each individually navigate the world. So one set of regulators we could identify in, for example, the community context. So thinking about health-seeking behavior, we might be interested in what's the general health environment. That would be things like just access to healthy resources, access to primary care physicians. What's the reproductive health environment? So access to specialized care around reproductive health. What's the behavioral health environment? What's the transportation environment? And importantly, what's the social support environment? Each of these things may shape the constraints and opportunities that guide how an individual navigates their life and navigates their pregnancy and their postpartum period. But those things don't just exist in a vacuum. The differences that we see between neighborhoods, between resources, are created over time through structural processes. And so we can think of some fundamental social determinants, things like social population stratification, segregation, historic redlining, funding patterns of rural versus urban hospitals, et cetera, as fundamental social determinants. And then the last thing I want to point out in this framework is this idea of embodiment. So we can imagine these constraints and opportunities changing our behaviors, but how does it affect our biology? Because so many of the things we're interested in are, you know, at the end of the day, biological outcomes. How does it change our biology? I don't mean genetics, I mean biology, like our physiologic functioning. And this process of embodiment is one way that scholars and scientists have begun to describe this process. The probably best example we have is the really robust literature around chronic exposure to stress and preterm birth. But there are many other examples of how social experiences actually change our biology. One of them being simply being able to access healthcare, right? If you needed healthcare and you didn't get healthcare and your biology changed as a result, that access, that social access to healthcare changed your diabetes course or your hypertension course. So embodiment as this thing that loops us back to what's under the skin. All right. So those two ideas, those curves of birth weight and the shifting distributions, asking about what's different between individuals versus what's different between groups, and then that framework, which is understanding or unpacking a little bit, how might that be produced? Those kind of bring me to these take-home points, that our health is caused in a multi-level set of ways, that if we want to understand health disparities and health inequities, we need to think about all of the levels, not just one of them. So biomedical and clinical health is definitely produced by individual traits and individual choices, but also social resources and opportunities. And contextual, environmental, or group level processes are necessary if we want to explain or understand disparities. Okay, what I want to do now is shift to some specific examples of social determinants of health that are evident in Georgia. And I'm going to just highlight several pieces of research from investigators in Georgia that helps us maybe make concrete some of these different things and what they might look like in our state. You all may be familiar with there's a number of these kinds of figures of the social determinants of health. This figure is borrowed from CDC. Identifying these different domains of what kinds of social factors and processes and forces shape our health. So, for example, we know that education, access, and quality seems to be a really fundamental social determinant of health. Healthcare and quality is really important. Neighborhoods and built environments, so the context that we live, work, and play in. Social and community context, and economic stability. So what I'm going to do is try and give some maternal and some perinatal and infant evidence pieces around each of these. I'm going to start with this one of education. So education is both a tool that helps us, for example, be health literate or be able to navigate complex situations, but education is also a proxy to some degree of our socioeconomic status, right? Our ability to get certain positions or jobs, to make certain amounts of money, to get health insurance, et cetera. So it's a proxy both for learned skills, but also for socioeconomic position. So what I'm showing here is from a paper we recently put out describing severe maternal morbidity in Georgia. I have a plot with the red line is the rates of severe maternal morbidity per 10,000 deliveries in non-Hispanic Black women. The blue line is non-Hispanic white women. Now, what's on the x-axis is maternal education. So her education at the time of delivery. And it ranges from women who have less than an 8th grade education, 9th to 12th grade, but they didn't graduate, don't have a certificate or GED, those who did graduate, high school diploma or GED, and those with some college. So we can see a couple things. We see obviously the racial disparity, so this persistent racial disparity in SMM, but we also see this gradient. So higher education is associated with lower rates of severe maternal morbidity. I want you to note that having a college degree does not erase the racial disparity in severe maternal morbidity. We still have substantial racial disparities, even with some college, and if we went out to having a bachelor's degree or even having a graduate degree, we see persistence. But we definitely see this gradient. If we look at the same pattern for babies born preterm, and if we looked at it for infant mortality, it's also the same, of a gradient of protective effects of maternal education on the outcome. All right, so that's one domain of social determinants, our individual socioeconomic status or education. So another one that we're really interested in, and I think that's really salient to GaPQC, is thinking about access to care. So you all may be familiar with March of Dimes's maternity healthcare desert project. So they've created this map for all counties in the US, and they identified the amount of maternity healthcare in each county. This is obviously just Georgia. The dark purple are places with essentially no access within the county, as is to say no OBs or no delivery facilities within the county. So people are traveling outside of the county. And then it's great, the gradients as the colors go lighter, go to high access. So we see this pattern, which I think is probably familiar to many people in this room. It certainly has been an important topic of discussion as we've talked about the closure of rural hospitals and the importance of access in rural communities. But it's a pretty profoundly large gap with populations having literally no access within their county and needing to drive an extreme distance. Now, this map isn't quite as pretty. This was actually produced by a group at Georgia Tech about 8 or 10 years ago. So it's a little older, but I suspect it still is approximately accurate. This is looking at spatial accessibility to pediatric primary health care. So that was maternal health care. This is pediatric primary health care. And it's actually a very similar pattern where the urban areas have substantial access, but the rural areas don't just have less access, they often have almost no access, or at least many rural areas have substantially reduced access. So this idea of our access to even the presence of healthcare and then the quality issue being another important social determinant. Okay, in thinking about this, there was some really nice qualitative research that was done by a variety of scholars in Georgia, where they identified women who delivered in high access areas and in low access areas, and they carried out some intensive informant interviews and focus groups. And they organized the findings of these women's stories about how they access prenatal care under a framework called the 3 delays of care framework. And you may have heard of this before. It's often used in a global health setting. And the idea is that the things that can delay receipt of the optimal care can be sort of divided into 3 steps. Are you seeking care? Did you access the care after you were seeking it? And then once you accessed it, did you receive the appropriate care? So these 3 steps. Now, these are themes that emerged from talking to women in Georgia who, again, were in high access and low access areas about each of these delays. In terms of seeking prenatal care, many women didn't identify this as a barrier, but those who did, it was often around awareness of pregnancy. So thinking about the importance of unintended pregnancies as an explanation for delays in care. And then different amounts of knowledge about the importance of seeking prenatal care early. And in some cases, particularly teen births, stigma around pregnancy. But I think the second and third delay are even more interesting. So the second delay, this is someone chooses to seek care, but the question is, can they access that care, right? Once they make the decision, I want care, can they get it? And the themes that emerged here was women really struggled with accessing insurance. So we know the challenges with going from not being on Medicaid to being eligible for pregnancy Medicaid, but not necessarily being able to get all the paperwork done. And depending on who's guiding you and what's happening, you may or may not know that you can seek care while that process is pending. Also, maybe getting Medicaid and then not having a provider in your community who is currently accepting Medicaid. So maybe somebody who's proactively trying to get care but doesn't have access to a provider who can cover them. So that's a delay in terms of accessing. And then the third delay is about receiving appropriate care. So they've accessed care, but did they feel like they got the care they needed? And the themes that emerged here were just the difficulties with consistency and continuity of care. I think challenges that all of us are familiar with, and undoubtedly that you all are doing lots of work on, and that's how do we think about referral systems and within hospital handoffs, and how do we think about the messaging that happens between outpatient and inpatient, and whether records are getting transferred and whether understanding is happening between the emergency department and other settings. So these things are things that emerge as barriers to accessing care for women in Georgia. All right, so I'm going to move now to another social determinant. This is economic stability. So economic stability may seem like a more distal, less obvious determinant of perinatal outcomes. But was this really interesting paper that came out just a couple of years ago in 2021 that was looking at evictions. So being evicted from your home is a symptom of economic instability. You can't pay your rent, you get evicted from your home. The study design was really fascinating, I thought. They identified in Georgia about 90,000 people in a 10-year period, 90,000 women in a 10-year period who were evicted. And all of them had a baby in that 10-year period. So they'd all been pregnant and they'd all been evicted in the 10-year period. 10,000 of them were evicted during pregnancy, and the other 80,000 were evicted at a time outside of pregnancy. So what they were able to do is compare these two, because we know that if you just look at people who are evicted to the total population, there's lots and lots of things that might be different, might be confounders. And by looking at only women who were evicted at some point, there was more similarity. And what they found is that comparing women who were evicted during pregnancy to women who were evicted at some other point that wasn't during pregnancy, the prevalence of low birth weight and preterm birth were both increased in absolute terms by about 1%. And there was actually an additional 2 infant deaths per 1,000 live births. So economic instability leading to housing instability, eviction, strongly associated with perinatal outcomes. Now, neighborhood and social context is a really important and often frequently studied. We have a pretty robust literature, particularly for pregnancy outcomes, for perinatal outcomes, pretty robust literature around neighborhood effects and perinatal outcomes. This is a really nice paper done by Dr. Maddie Wolf, who's a neonatologist here at Emory. And this is just one summary of it. She was interested in neighborhood deprivation. So that is a measure at the census tract level. So a census tract is kind of like your neighborhood. A measure at the census tract level of a number of different indicators of the material wealth and resources in that community. So is this place a place that has a lot of resources or a place that has fewer? And so higher deprivation is fewer resources, right? So on the x-axis of this graph is quintiles or buckets, 20% buckets of deprivation. So all the way to the right are neighborhoods in Georgia with the highest deprivation or the lowest amount of material resources. All the way to the left, quintile 1, are the most affluent neighbors, the neighborhoods with the lowest deprivation. And what we're showing here is model predicted infant mortality rates. Again, this is Black women in red, or Black infants in red and white infants in blue, across those quintiles of neighborhood deprivation. This is from a model that is adjusting for maternal education, maternal age, marital status, smoking, plurality, and infant sex. And what we see is this really profound gradient of increased risk of infant mortality for women living in the poorest neighborhoods. It's true for both Black and white women, although again, we still see this really profound racial disparity with no overlap. For example, white women in the very worst neighborhoods still have better outcomes than, or white infants in the very worst neighborhoods still have better outcomes than Black infants in the best neighborhoods. So neighborhood context seems to be really important. And then the final one I'm going to talk about is community context, so a broader social pattern. And this is from a now graduated doctoral student, Katie Labgold, from her dissertation. She was interested in segregation, and specifically, she was interested in residential segregation by race and class. In other words, how we sort ourselves in terms of where we live seems to be really important for a number of health factors. And she wanted to know, is it more about racial segregation, more about economic segregation, or both? Her study was specifically on severe maternal morbidity. So this is in Georgia, using census tract, neighborhood, segregation measures, and looking at severe maternal morbidity. And the way she categorized it, let me orient you to this. We can imagine that there are the neighborhoods that are the most affluent. So concentrated affluence, that's one kind of segregation, right? Everybody is alike and they're well off. So concentrated affluence are the two bars to the left. The red bar means that it's concentrated affluence and also predominantly white. And the purple bar is concentrated affluence. And this says concentrated persons of color. So because across the state, there's a number of different communities, this included Asian, Hispanic, or non-Hispanic Black. So the purple and the red line in concentrated affluence were actually very similar. The very lowest rates of severe maternal morbidity were in the places with segregation, but a kind of segregation that meant everybody around you was well off. And it didn't actually seem to matter whether the neighborhood was predominantly white or not. Now, if we go to the opposite end of the bars, the concentrated poverty, these are neighborhoods, not just where there's some poor people, but where most people are poor, where there's a segregation such that people are concentrated, poor people are concentrated in physical space. And here we see the highest rates of SMM, and we also see this distinction by racial segregation, so that if it's a neighborhood characterized by concentrated poverty and concentrated persons of color, again, in most counties or most neighborhoods, this was predominantly non-Hispanic Black, we see even higher rates of SMM. So this gradient along both economic segregation, one measure of community context, and racial segregation, another measure of community context. All right, so that's just a sampling of the kinds of evidence that we have. We have a lot of kinds of evidence, and some of them are things that are well outside of the scope of GaPQC's levers, and I recognize that. And some of them are inside that scope. And so what I want to spend the last couple minutes talking about is how you might go about thinking about your scope and your job and how you approach this. So what does health equity in GaPQC look like? I want to just bring us back to this idea that whatever you're doing, an in-hospital quality improvement process or a between-hospital process, a system-wide process, whatever, that when there's an uneven playing field, treating everyone equally perpetuates inequity. You really, to center equity means to think consciously about how the implementation is going to help make everybody get the best help they could have and not provide everybody with exactly the same resource. So centering equity, I think, is really important. This was my brainstorming about how you might think about different levels of things that you could engage in. I think things that you're already engaged in at the patient and provider level are identified here. So thinking about providing health education that's culturally appropriate, making sure that each person's treated with respect and listening to concerns. I think there's already been some work done on thinking about implicit bias for providers, but really importantly, thinking about provider and staff diversity. We know we have a lot of evidence now that when the medical staff that's at all levels of medical staff, providers and front office, when they reflect the diversity of the community they're serving, there is often better outcomes. And it's not because people are intentionally discriminating. It has to do with navigating spaces where you feel welcome. So thinking really about what are we doing to improve provider and staff diversity. At the facility level, I think there's lots of opportunities. If you're thinking hospitals, they're open all the time, but many of the barriers to accessing outpatient care have to do with accessing care for working people. So do we have geographically accessible care, but also do we have care that's provided at hours that match the demand? At the system level, thinking about this challenge of navigating systems, do we have navigators and other supports that can facilitate and help with care coordination? And I want to come back to this respectful treatment, which I also put under patient. I think this is a health system perspective too, right? Thinking about respectful treatment from entry to exit. So how you're treated, not just in the exam room, but also at registration from everybody all along the way. Now, as we get to these last two, these are getting a little more outside of the hospital, but I also feel like they're fundamentally the things that are going to make the most difference. So we got to figure out where each of us individually is, where you all are as GaPQC with respect to these. So one is thinking about health context and policy. Medicaid expansion. We had a really important move with the expansion of postpartum Medicaid to 12 months. That's significant. But we also know that a lot of women enter pregnancy with uncontrolled hypertension, with other unmet medical needs. Medicaid expansion or other approaches to figuring out how to provide primary health care to all people is really important if we want pregnancy to end well. We can't imagine that we can just provide care at pregnancy and make up for the absence of care at other points in time. So thinking about how do we improve that? Novel services needing Medicaid and other support. So there's some interesting examples from other states of using Medicaid funds, for example, for emergency housing support, or for vouchers for Uber to get to your postpartum appointment, things like that. Like, do we need to think about identifying barriers to housing or transportation, and what are the levers that we have available to meet those? And then certainly, thinking about how do we support rural hospitals and providers. That's both about keeping rural hospitals open, but also incentivizing and retaining providers in rural communities. And then this last one is getting outside of the health zone. But again, I think fundamentally addressing the things that are driving inequities. And that's thinking about just and fair investment in communities. Making sure that our investment results in housing that's affordable for people so that people can live there, that there's jobs. Thinking about housing supports and thinking about environmental policies that share risk fairly. Now, along the bottom of this, I have these kind of 3 things that you all could be doing. We can think about action. Some of them you're already doing, you can implement easily. Evidence, things that you can be thinking about collecting evidence around to inform future. And then this advocacy piece, I don't exactly know where GaPQC is with respect to advocacy, but as individual professionals, I think you have the opportunity to be advocates in a number of ways for these roles. So that's what I've got for you today. I think I've got a few minutes for questions, and I really appreciate you all having me.